We have been dispatched to the fair town of Canterbury, England, mutual aid for a man who has supposedly fallen off his horse. As we approach the scene, we can see that he is our only patient, and there does not seem to be any threats, whether it be wild animals or invading armies, to us or our patient. As we approach our patient, seeing the mechanism of injury and the general impression that we have on him, which is not very good, I will direct manual C-spine to be taken by my partner. Another aspect to my general impression is that he took quite the blow because his helmet has fallen off. We will begin by assessing our patient's level of alertness. Because he does not appear alert right now, not moving, he is not alert. We will then assess for a verbal response. Good sir, are you there? In which he does not respond. We will then try painful response, by giving him a sternal rub. And no response. Because of this, he is unresponsive. And we begin our primary assessment. We will start with the airway. I can hear snoring respirations, which implies that his tongue is blocking his airway. So we will put in an oropharyngeal airway. Properly sized, inserted, and all airway threats appear to be taken care of. We will then assess the breathing. We do have equal rise and fall of the chest, but it does not seem adequate, only at 6 breaths per minute approximately, and very shallow. Therefore, we will bag him with a BVM at 15 breaths per minute on high flow oxygen. We then assess our circulation. We do not see any gross bleeding anywhere, so that is taken care of. The skin appears to be pale, cool, and diaphoretic. We do have a carotid pulse, and we do have a peripheral pulse on the arm. Therefore, we will then begin our transport. So after the primary assessment is completed, we will make our transport decision, which is immediate. We will then, very carefully, put on a C-collar, bring him on a backboard, per National Registry standards, put him into the ambulance, and then we'll take off from there. But before we leave, I'll ask around if there's anyone who can give me a sample history. Anyone? No. So unfortunately, we cannot obtain one. Once we are inside the ambulance, we will begin our secondary assessment. We will start by stripping all clothing from our patient, making him trauma naked. I'm not going to cut that because I actually like these pants and shirt. Once our patient is trauma naked, we can begin our secondary assessment. We'll start with our baseline vitals, which includes blood pressure, pulse oximetry, and a 12-lead EKG. Once that is taken care of, we can begin our secondary assessment, starting with the head. On the head, we will check for any decap BTLS. And there does appear to be quite the contusion right on the side of the head. As we move any further up, we will check the orbits for any fractures, which there is none. The jaw, with no fractures. And with that, we will check the eyes for a pupillary response, in which there is an unequal pupillary response. We will then move on to the neck assessment. Even with a C-collar on, we can still check for JVD, or jugular venous distension, or any tracheal deviation. We'll check for decap BTLS as well, and we'll check the back of the neck for any stepping, in which there does appear to be some between C3 and C4. Nothing we can do about that now, except make extra sure that his head stays where it is. Moving on to the chest. We'll check for any decap BTLS, which there is none, and we'll also be checking for flail segments, which there is none. We'll be listening to breath sounds, which are all clear bilaterally. And we'll move on to the abdomen. We're checking for any tenderness or rigidity in all 4 quadrants, in which there is none. And we will check the pelvis for its stability, which it is. And then check the genitalia area. Our patient is male and does have a priapism. With that taken care of, we'll move on to the lower extremities. Checking for decap BTLS, much of the same. in which there is none. We'll then move on to the other side, assessing the extremity on our side for the same. No blood, no bleeding, no deformities, or contusions, or hematomas. So we are in the clear for the lower extremities. We'll then assess the upper extremities. For decap BTLS, and there is none. Peripheral pulses are present, weak and thready. And for the other upper extremity, there does appear to be a fracture right on the forearm. You'll splint that in place if time allows, which it does, so we'll splint it in place. Check for peripheral pulse, which is present, and thus ends the secondary detailed exam. We will then reassess our patient every 5 minutes until he is brought to definitive care. This ends the station.